Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to you. This week's topic, hip and knee pain. What's causing the pain and what are the options for treating it, including replacement surgery? Our guest is orthopedic surgeon Will Moore. First, some background. Dr. Moore received an undergraduate degree in mechanical engineering from Princeton. His medical degree is from Vanderbilt. He completed his residency in orthopedic surgery at the University of Alabama in Birmingham. He completed a fellowship in joint replacement at the Anderson Orthopedic Clinic in Alexandria, Virginia. And it is our pleasure to welcome Dr. Will Moore to Hello Health. Good to have you with us on the program.
Thanks so much. Pleasure to be
so
here.
Dad played football for Alabama.
He did, yeah.
And you're married to an LSU
grad.
LSU grad.
Sure.
So who are you rooting for in the home?
Well, it's I
know who you're rooting for.
Yeah, it's a mixed family, and I'd definitely pull for Alabama still, but I'm surrounded by Tiger fans here, so I've got to.
And living in Louisiana, that's
for
right.
Sure.
You also wanted to point out, interestingly, that you spent 14 months in Kenya. What were you doing there?
So between residency and fellowship, I spent 14 months in a place called Tenwick Hospital. It's a mission hospital in Western Kenya, doing orthopedic surgery, mostly trauma surgery. But it was just a kind of a once-in-a-lifetime opportunity before kind of starting practice to really give back and to just have a great new experience and perspective changing. It was part of a mission agency program that would sponsor you right out of residency, and life and perspective changing in many ways. Yeah.
I would imagine most people who want to end up in medicine don't start off in mechanical engineering, but you found it helpful since then, right? Sure.
My main background was orthopedics, and kind of through that realized that I could do orthopedics, and with the mechanical engineering side of things, I like playing the machine shop, using hammers and drills and saws, but actually making a one-on-one difference with people, and kind of seeing something that was broken and fixing it, and using that kind of mechanical background to do that. It's been a great combination.
Even altering some of the instruments you use, right? You said, man, if this could be over just a little bit, in fact, let me do it, right?
Yeah, so especially my hip replacement sets, I've had my rep kind of weld in certain tabs on one part and kind of change a curve here and reorient something here. So all in the ability to kind of do the surgery a little more efficiently.
Everyone's different. Let's talk about causes, the primary causes of hip and knee pain in adults.
Sure. In clinic, we screen out people for hip and knee pain. And predominantly what I do is hip and knee replacements for arthritis. But there's a lot of other reasons that people have hip and knee pain. And we spend a lot of time in clinic kind of working through those other diagnoses.
So what are some of the common complaints you get about hips?
Sure. We start from the top. We talk about hip pain. That means a lot of things to a lot of people. And specifically, I say, when you say hip pain, point to where you hurt. Because classically, the hip joint is really the front of the hip and the groin, the anterior thigh, but a lot of people come in and say, oh, doc, it's my low back or around the back. And that's actually most commonly related to your low back, your lumbar spine, and where your spine hits your pelvis in the back. So a lot of people come in complaining of saying it's hip pain, but it actually turns out to be their back.
So hip pain can cause pain in other areas. In what other areas, and why is that the case?
You've got a lot of muscles that are attached between your spine and your pelvis. You could have arthritis in your lower back. You could have a pinched nerve that could give you pain down the back and down the back of your leg. But a lot of it is just taking a good history and doing an exam to figure out exactly where people are hurting to kind of give them an appropriate diagnosis.
What about pain at the side of the hip?
So that would be another common complaint that we get when people say their hip hurts. They actually point to their side of the hip. And that's a pretty classic location for what we'd call hip bursitis. Bursitis is kind of a catch-all term for inflammation or soft tissue inflammation. You've got muscles that attach to the top of the femur there, and those are the main muscles that move your leg. They support your torso when you stand on one leg or you do stairs. So it's a lot of force on a very small area, and a real common place to get some inflammation. There's also a little fluid-filled pocket. That's what we call a bursa, and that can get inflamed as well. But again, it's kind of a catch-all term for the soft tissue inflammation on the side of the hip. Really common, see it multiple times a week. And typically we can do some physical therapy, some targeted injections, some anti-inflammatory medication, and some activity modification and get that to calm down. But it is, people come in worried about that it's their hip joint, and it's actually the side of the hip and the muscles around it.
We'll get back to the hips, I promise, but first let's move to the knees. What are the sources of pain in the knees?
Sure. So again, kind of taking a good exam, getting a good history, figuring out exactly where people are hurting and why. There can be several causes of that.
Start with the anterior knee pain or pain in the front of the knee. What would cause that typically?
Yeah. So anterior knee pain or patellofemoral syndrome is, again, kind of a catch-all term for pain in the front of the knee. You've got your kneecap, it runs in a groove on the end of the femur. You've got a bunch of soft tissues that are connected to that, and it's a real common place to get some discomfort. That could be from a little wear and tear on the back of the kneecap, a little early arthritis, but it could also be from soft tissue inflammation and irritation of the muscles around the knee. Sometimes there's a mismatch of how the kneecap tracks along the femur, and it's actually a very common thing. And there's some things we can do non-operatively in terms of anti-inflammatory medication, some physical therapy, potentially some targeted injections again, but it's typically not something that needs surgery.
How about pain at the side of the knee? What could that be an indicator of?
So just like we talked about, you can get bursitis on the side of the hip, you can actually get that at your knee as well. So basically the same soft tissues that run down the side of the hip go all the way down the side of the thigh and down to the knee. So especially in more active athletes, the classic story is somebody that just started training for a marathon, they'll get some pain on the outside of their knee, and it's actually because of the essentially friction from the soft tissues rubbing across the bone on the side of the knee.
You mentioned your dad played football at Alabama. It was a different day back in the time. Now it seems like we all know the term meniscus, right? We hear that when we're hearing about athletes and them going on the injured reserve list or out for the season. So what is the meniscus and what is a meniscus tear and why is it at such high risk?
The meniscus is essentially a soft tissue shock absorber and stabilizer. It's a little C-shaped ring of soft tissue. You've got one on the inside of your knee and one on the outside of your knee. And it's between the thigh bone and the shin bone. And they can be damaged. Some of it is an acute injury where you twist or turn wrong, and some of it is they just wear out over time. And that's usually what I see in clinic. Typically pain is at the joint line, either at the inside or the outside, and you get what we call mechanical symptoms, which is a fancy term for basically some catching or locking or something feeling like it's getting stuck when you're moving the knee. A lot of times we can tell that on exam, but often we need an MRI to really give us a look of that soft tissue and that meniscus.
To this day, I'm convinced that one of my legs is at least an inch longer than the other one. Am I likely to end up with knee pain or hip pain or a combination of both or not necessarily?
Yeah, if you look at the data, people can tolerate a significant amount of leg length discrepancy before we would say that you would specifically get arthritis or some true wear and tear related to it. Could you get some muscle strain or a little bit of pain from that? Certainly. And are there people that have significant leg length discrepancies, like significant differences that get imbalance of their muscles and get back pain and hip pain and knee pain? Certainly. But most people are sometimes, several millimeters to centimeters different, and for the most part, that's tolerated pretty well.
Are some people at higher risk of developing arthritis and some of these problems coming on earlier than later?
Sure. There's some significant genetic factors that are related to that. So we kind of say the arthritis can run in families essentially, and whether that's an issue with how people's cartilage is formed or certain proteins that make up those cartilage, there's certainly some genetic components to that. And I think we're figuring out more and more of that every day. A lot of it is injury related. So whether that's sports injuries as a child or growing up, or even later injuries in life, those certainly can stack up over time and lead to arthritis. For hips, we know that I think more and more we're recognizing that if the hip socket and the ball are a little bit out of line, just in terms of how the joint was created and how it developed as a young child, you could be at increased risk for early wear and tear down the road, almost like if your tires are just a little bit out of line to start with, they may wear out faster. And then there are, medications, and there's even lifestyle risk factors that can put you at increased risk for arthritis. We know that, just like if you overload a car or a truck, you're going to wear out those tires. People that put more force on their joints and weigh more could have higher rates of arthritis. And especially in a town like New Orleans, we know that people that have a history of heavy drinking can lead to more severe arthritis, and especially their hips, and we see that a lot as well.
And obesity could be, again, more weight on the joints, right?
Certainly.
Okay. You also wanted to recommend a place online to get more information for people who wanted to learn more to go.
Yeah, if people ask if there was one resource that I would recommend in terms of finding some true kind of peer-reviewed literature or information about a diagnosis, or some specific treatment options and even therapy options. There's a website called OrthoInfo. It's put out by the American Academy of Orthopedic Surgery. So all the articles about the specific diagnoses are written or reviewed by orthopedic surgeons. And I actually use the home exercise programs from the website for hip and knee pain routinely for people that either can't get to or can't afford physical therapy.
Great, and we'll try to put that up at the end of the program as well. So we ruled out some of the common problems, reasons for hip and knee problem. Let's dive a little deeper into your specialty of arthritis.
Sure. So once we've kind of gotten a good history, gotten an exam, kind of ruled out some of the other differential diagnoses, and we really feel like it's arthritis, people ask, what is arthritis? And there's a lot of misconceptions about the terms. Arthritis basically just means joint inflammation. Osteoarthritis is kind of the standard catch-all term that we use, and that's the typical run-of-the-mill, my hip or knee wore out over time.
Bone on bone, or
bone
some
on,
semblance.
Bone on bone is kind of the end stage when all the cartilage is gone. We talk about that. Everybody likes the term bone on bone. It sounds great.
Well, people don't like the term bone
or
on
not.
bone. Right,
And then there's a whole nother category of arthritis, and that's the inflammatory arthritis. You heard of rheumatoid arthritis. There's several different kinds. And those are basically, for some reason, the body essentially starts attacking your own joints. And that's a whole separate category. And people sometimes really get confused about those two different things.
What are the symptoms of hip arthritis? What are you looking for and what causes it?
So mostly pain and limited function and limited range of motion. The pain typically is in the groin and the front of the hip or the anterior hip. Occasionally it's what we call a C sign, where it radiates around to the side, but it's usually not just the back or just the side. There's typically a front of the hip component to it. There's also some anterior thigh pain, and that can go down to the knee, but not usually below. A lot of people actually come in complaining of knee pain, and it turns out to be their hip joint, because the nerves that go to the hip joint cross over with the nerves to the knee joint, and so we call that referred pain from the hip.
That was hip arthritis. What about knee arthritis? What are you looking for there, and what would cause that typically?
So essentially knee pain. So where you have the wear and tear is usually where the knee hurts. And a lot of times if the whole knee is worn out, people just say my whole knee hurts. You can also get some pain in the back of the knee, because when you have a worn out knee, the body tries to lubricate the knee to keep it moving. Eventually you get so much fluid in that joint that it's got to go somewhere, and it kind of works its way into the back of the knee, and you can get some fullness back there as well.
Take people into a visit with you. For coming to see you for the first time, my hip hurts, my knee hurts, maybe they both hurt. How many patients, by the way, Doc, I'm a wreck. My knee hurts, my hip hurts, help.
Well, there's a little bit of that, and a lot of times a hip and a knee will go on the same side, and we have to kind of wade through and maybe pick one or two and start there and see where we end up. But we typically have a pretty standard formula for working through things. We get a good medical history. We talk about general medical history, specifically issues that may make surgery more difficult or may need to be optimized prior to having surgery. We do some specific orthopedic questions about what have they already tried, what medications, injections, therapy, bracing, things like that. We need to know where we are on that spectrum for treatment options, and then also we need to document some of those if we do need to go forward with surgery. We get a good history of the pain that they're having and the issues that they're having, and we get a nice physical exam. And I always kind of examine the hip and the knee both times, because a lot of times those are related. We look at people's x-rays, and I really like looking at x-rays with the patient, because I think if a picture is worth 1,000 words, and if you can actually see what's going on, you can really understand it better. And then we discuss our treatment options, and often that's surgery, but sometimes it's not. And we talk about what we can do prior to surgery to help increase function and decrease pain.
Before I move to that, is part of the history, do you care if I was an athlete or not, or if I'm a biker or any of those?
Yeah, so one of the specific parts of my kind of orthopedic questions that I have are, what does the joint keep you from doing that you want to do? So we talk about what, everybody has a different goal in life, and everybody has a different kind of expectation for what they need to be able to do. We talk about what they do for a living and kind of what social support that they have, because all those play into what your expectations are with surgery and what our options are for doing therapy and post-op rehab. But the person that wants to go back to running marathons is going to be a very different person than the person that just wants to walk down the street, because we have to kind of treat those people a little bit differently.
Is part of your job to letting people manage their expectations, right? So if I walked in
Certainly.
and said, I'd like to play in the National Hockey League,
Yeah.
you start with, well, have you ever played hockey? No.
Exactly.
Right. Well, it's unlikely I'm going to get you there, right?
Yeah.
So is that part of your job too?
Yeah, if you weren't running a marathon beforehand, I don't know if I'm going to get you to that point. But certainly, kind of figuring out where people are and what their expectations are goes a long way in kind of meeting expectations and making people have great results.
So surgery is an option, but let's talk about the options before we get to surgery for arthritis.
Sure. Orthopedics is pretty basic. There's not a whole lot of options, but the things that we do have work. Anti-inflammatory medications, injections, exercise, whether that be on your own or with physical therapy, some type of compression device for some support. And then we also spend a lot of time talking about weight loss. In terms of anti-inflammatory medications, a lot of what I recommend is just over-the-counter. If you look at the data, the over-the-counter stuff really can be just as good as the prescription strength things. They're a little easier to take, they're a little easier to titrate, and in some cases we do use some of the prescription anti-inflammatories. In terms of injections, the two that we use mainly are steroids or cortisone, and then another option from that would be the synthetic injections or hyaluronic acid. We use a lot of that in the knee, not really for the hip. And we kind of talk through the pros and cons of those things. The vast majority of injections we do are the cortisone or steroid injections because those have the best data behind them. There's a couple other different kinds of injections people talk about. One is PRP or platelet-rich plasma, and the other is stem cells. And we talk about those, but typically insurance doesn't cover those right now. I think there is some data around PRP for arthritis. I don't think the technology is there yet for stem cells. And so that's a discussion that we have with the patient in terms of what their expectations are and what their options are.
What about patients who stay on the conservative side with anti-inflammatories kind of by the drugstore, but worry about long-term use? Is there real concern there?
Sure. All medications have side effects, and we talk about some of those when we discuss kind of how much to take and how often and for how long. I worry about stomach upset. I worry about potential blood pressure issues, heart problems, kidney problems. And so we talk through some of those things in clinic. My general answer is if you're on any of those medications for more than a couple months, you really should have that managed by your primary care doctor because they're the ones following your blood pressure and your kidney function and all those things on a long-term basis.
When should a patient start to consider some sort of surgery?
Basically, when we've worked through those options in clinic and we've talked about that you've got a history that makes sense. So you've got arthritis on exam. You've got arthritis based off your history. Your pain seems to be coming from that specific joint. And your exam localizes to that joint as well, which means that, it doesn't seem like it's some other pain generator, like something referred from your back or something like that. You've got x-rays that go along with the symptoms, and that we've tried everything else. So we've done all the non-operative things that make sense, and the hip or knee is still keeping you from doing what you want to do. You're having more bad days than good, and we've optimized you in terms of other potential medical issues.
Talk about the different types of surgery, starting with an anterior hip replacement, coming in through the front, right?
Yeah. So hip replacement itself is essentially a resurfacing of the hip joint. There's a metal socket that we put in the pelvis with usually a plastic or polyethylene liner, and then there's a metal stem that goes in the femur side with usually a ceramic or metal ball on top of it. And there's basically, when people talk about approaches to the hip, you're talking about where do you make the incision and what's the interval that you use to get down to the joint itself. Once you get to the joint, the surgery is pretty much the same. You put a cup in, you put a stem in, you put a ball in. That's pretty similar across all the options for hip replacement surgery. The gold standard kind of historical classic way to do this is what's called a posterior lateral or posterior approach, where you make an incision off the side of the hip. You have to split some of the muscles, you have to cut some of the tendons and muscles and capsule to get into the back of the hip. And so what's called an anterior hip has been developed to try to eliminate some of those factors with the surgery approach.
Where's that incision?
So we make the incision in the front of the hip. We go between the muscles instead of through them. And we don't cut the tendons or the capsule in the back of the hip. I can use a special table to position the leg. I think we'll talk about that in a little bit. And the advantage of that, a little less invasive. I actually use an x-ray machine to kind of know exactly where I'm putting the parts. I can, I think, balance the leg lengths a little better because I'm looking at it on x-ray. And we'll talk about some of the advantages of that approach as well. But low seems to be, people get up and get moving a little bit faster. There's a lower dislocation rate. And overall, just kind of a quicker recovery, I think.
Does body size have anything to do with it? So with a heavier patient, that may not be an option or might be a better option?
So body size is an option, is a factor in all of surgery. Certainly there are some people that we think are at a limit where it would be safer that they lose some weight before surgery, because we know that once you get above a certain height-weight ratio, your risk factor for infection, wound healing problems, dislocation, and implant failure start elevating significantly. And so in terms of the anterior approach, I can do it on most people. The one issue, a couple issues, if they've had previous surgery, if they have the hardware in place and screws and things like that that I need to work with, sometimes it's a little too complicated to do it through the front. The other thing is if basically they just have a big belly that's going to kind of overlap where the incision is going to be, and then that would be not safe to put that incision there.
All right, Dr. Moore was kind enough to let the Ochsner production team into the operating room, so we're going to take a look at one of his surgeries right now.
This is our patient. She's a 58-year-old with severe left hip arthritis. The hip bones on either side, and then this is the right and left hip socket, so it's like the patient is standing facing us. This is a little bit of wear and tear, a little bit of early arthritis in the right hip, but you can see a normal hip socket and a normal ball, and there's a clear space in between. That's where the cartilage is. On this left side, you can see you can't find that clear space because the bone of the socket and the bone of the ball are right up next to each other. So that's severe end-stage hip arthritis. All the cartilage has worn away. When things have gotten this bad, the best option is a hip replacement. I thought she would be a good candidate for an anterior approach hip replacement. Some of the advantages of that anterior approach are that I can use a live x-ray machine, so I know exactly where I'm putting the parts while we're doing surgery. It helps me match leg lengths and offset and really dial in some of the implant positioning. We also can do it through a relatively smaller incision. We go between the muscles instead of through them, and there is a documented lower dislocation rate. I think people seem to get up and get moving a little bit faster, and there's some significant advantages to that. This is where we ended up. You can see she's got a metal cup. Because of the severity of her arthritis, I put in several screws. There's a plastic or polyethylene liner that snaps into that cup, and then there's a metal stem that goes down into the middle of the thigh bone, and there's a ball on top of the stem. But she did well, was able to go home after one night in the hospital, did therapy, went home the next day, and expect great things.
Recovery from this is going to be at first some home therapy, right? Kind of a stepped approach. Clearance by the medical team, which could include the surgeon, but other members of the team. And then some patients are going to go into physical therapy, right?
Correct.
Okay.
Yeah. Typically, people are walking up and down the hall, up and down stairs, in and out of a car before they leave the hospital. That's usually after one night, and eventually we'll transition into a same-day type procedure. And then for now, mostly home therapy. And then after 2 weeks, they'll come see a team member make sure everything looks good from an incision standpoint, and a lot of people are transitioning into more aggressive outpatient therapy at that point.
We got 1 minute left. Talk to me about the difference between a partial knee replacement and a total knee replacement.
Yeah. So if your whole knee is worn out, you need a full knee replacement. That's a metal cap on the end of the thigh bone, metal tray with a plastic liner on the top of the shin bone, and a plastic cap behind the kneecap. So we resurface the whole knee. We can reorient a knee. Sometimes people are significant bow leg or knock knee deformity, and that's, you can reorient all those things with a full knee replacement. A partial knee replacement would be indicated if you just have part of the knee that's worn out. The most common reason would be if just the inside of the knee is worn out, and you can resurface just the inside of the knee. The advantages of that are you don't have to cut any of the ligaments or tendons to do that surgery. The knee feels a little bit more natural, and the recovery is a little bit quicker. And the other advantage that we have at Ochsner is that we have one of the surgery robots to help us do that partial knee replacement. So I feel like the alignment of the knee is a little more exact, and the ligament balancing is a little more perfect for that.
Dr. Will Moore, thanks so much for your time. Appreciate it.
Appreciate
I want
you.
to thank Dr. Moore for the education and information he has provided and for his work in the Ochsner Health System. To make an appointment with any Ochsner physician, including this week's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at the number you see on your screen or send us an email. There's our address, hellohealth@ochsner.org. Love to hear from you. As a reminder, you can rewatch this week's presentation and many of our other Hello Health programs on Ochsner's website at ochsner.org. Our thanks again to this week's guest, Dr. Will Moore. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of this program, Hello Health. I'm Tom Bagwell, and we'll see you next time.